This is the MyHeart.net podcast. This show is produced by Dr. Philip Johnson in conjunction with VitalEngine.com. Please welcome your host, Dr. Alain Bouchard, a cardiology specialist of Birmingham, Alabama, at St. Vincent's Medical Center, part of Ascension.
Welcome to MyHeart.net. Today we're going to talk about the evolution and promise of GLP-1 agonists in cardiac patients with obesity. We're going to talk a little bit about what are GLP-1. We're going to talk about their effect on weight loss and try to compare it to the gold standard, which is surgery. We'll also describe some of the beneficial effects that they have in patients with cardiac disease. We'll talk about some of the side effects and maybe ways to mitigate them. And finally, we'll discuss a little bit about some of the future of these medications. And with us today, we have Professor Tim Garvey from the University of Alabama in Birmingham. He's professor of medicine in the Department of Nutrition Sciences at the University of Alabama. He's also the founding principal investigator of the UAB Diabetes Research Center. So, Tim, thank you very much for taking the time, and welcome to MyHeart.net.
Well, thank you, Ellen. It's really good to be here and see you again. I'm looking forward to our discussion.
Thank you. So, in the last 15 years, the landscape of diabetes and obesity management has been significantly transformed by the advent of GLP-1 receptor agonists, which are about to become the most successful drugs in the history of medicine, eclipsing drugs like insulin and statin. So, Tim, let's start with the beginning. If you could define for us, what are these GLP-1 receptor agonists and how do they work?
Well, there's a number of these GLP-1 receptor agonists. They are, for the most part, peptides, proteins that once they enter the bloodstream, bind to GLP-1 receptors on various tissues of the body and exert their beneficial effects. So they must be taken subcutaneously for the most part. There are forms that are encompassed in a matrix that allow absorption through the stomach. That formulation is available, so there is oral preparations as well. But for the most part, they're subcutaneous injections of peptides. As the name implies, these glucagon-like peptides bind the GLP-1. They're called glucagon-like peptide 1, but they bind the GLP-1 receptor, as I mentioned, at different organs of the body and have multiple effects. One more relevant to diabetes is they increase insulin secretion in response to a rising glucose. It's called an incretin effect. They also have other effects like slowing gastric emptying. They're moderately vasodilatory. But they also enter the brain, particularly the hypothalamus, but also the brainstem, and decrease appetite, leading to weight loss. So they have applicability to both diabetes and obesity. Now, our first GLP-1 receptor agonist that we had available for obesity was liraglutide. The brand name there is Saxenda. It's only moderately effective, I think, for weight loss. And it joins the previous, and that was first in 2014, what was it first approved for obesity. And there were other medicines such as phentermine, orlistat, the combination of phentermine, topiramide, which the brand name was Qsymia, and also naltrexone, bupropion, brand name there is Contrave. All these medicines approved by 2014 or before. The average weight loss in clinical trials was below 10%. Okay, sometimes far less than, 5% even on average. But since then, since 2020, we've had the introduction of a number of more powerful GLP-1 receptor agonists that produce more weight loss. And I'll just list those for you. There was semaglutide, up to a dose of 2.4 milligrams a week. This brand name is Wegovy. And there's tirzepatide that was just approved in November of last year for obesity under the brand name Zepbound. These drugs have been approved a few years earlier for diabetes with different brand names, but these are the brand names for, and the generic names for treatment of obesity. These medicines produce on average 15% weight loss or more. And to me, this is a transformational in the treatment of obesity. And why do I say that? Because that degree of weight loss is sufficient to prevent and treat a broad array of obesity complications and obesity-related diseases. If you're less than 10%, it's helpful, but it doesn't get the job done as well. So the benefits that we can bring to the table for patients are just so much greater with these second generation, what I call second generation obesity medicines, the high dose semaglutide and the tirzepatide. And I believe this is a landmark in the history of medicine. I think it will become to be seen that way because obesity is so common, and now we really have effective treatments with the GLP-1 receptor agonist.
Yeah, I think the impact could be really tremendous if we calculate that, 40% of our population, has a problem with obesity, and then probably another 30% with problem with overweight, and particularly us in the Southeast. It's a significant problem with certain population having, probably up to 49%, problem with the weight. How does it compare to the gold standard, which I consider, bariatric surgery?
Yes, we're closing the gap. I mean, if you figure the gastric sleeve, the lap band's not done so much anymore, but if you just consider the gastric sleeve and the Roux-en-Y gastric bypass, we're talking about weight loss of 25%, maybe to 35%, maybe 40%. Initially, many patients have weight regain over the ensuing years, but now with semaglutide and even more so with tirzepatide on these clinical trials, we're seeing average weight loss that overlaps. We can get patients to lose 25% weight loss on average with tirzepatide, for example. So we're closing the gap. And I can tell you, Alan, there's medicines in development, phase 2, phase 3 trials that are even more powerful that will definitely give us weight loss in the range of bariatric surgery. Not on the market yet, but hopefully they'll come to fruition.
Well, something that really got our interest in the cardiology field is some of the studies that have been done using these medications in patients that have coronary disease and had problem with obesity that were given Wegovy for 5 years, for example, the SELECT trial, and even some of the studies with heart failure, we're seeing, significant improvement in cardiac mortality, even patients that don't have diabetes.
This was another landmark development, the release of the SELECT trial data just at the American Heart Association meeting at the end of 2023 is when these data were presented and published simultaneously in the New England Journal. This kind of this has wowed the audience there, and it has really had repercussions. This is, this 20% reduction in cardiovascular disease events is just on top of in patients that are already on statins and angiotensin blockade for blood pressure. So this was just an impressive event. So, what this means, Alan, is this is a life-saving medicine, but yet, at least in the United States, patients have trouble accessing this medication. It's high cost, not covered by insurance for obesity in a lot of instances. And you mentioned that it's a very common disease, can affect up to 40% of Americans, obesity can. How do we reconcile all of this? I mean, we're going to have a dialogue about how we can make these medicines more available to patients with this common disease, particularly in patients that have a high risk or already have cardiovascular disease, because this SELECT study was really a secondary prevention study in essence. But that's a lot of people. And right now, people don't have access to what in essence is a life-saving medication. So this is something I'm passionate about. And I think we as healthcare providers and our patients really need to be advocates for each other in terms of um, making these medicines more available.
Oh, definitely. Now, they don't come without side effects, and sometimes it can be a little challenging, to manage those side effects. And some patients even will tell you they can't take it. So, how do we go about maybe helping a patient, with some of the, and if you could describe to us maybe some of the most frequent side effects that we encounter, and how can we help patients managing those side effects?
Yeah, the side effects from GLP-1 receptor agonists are all overlap. They're essentially, and it's gastrointestinal symptoms that are predominate here by far. We're talking nausea, vomiting in some patients, diarrhea, constipation. Nausea being the big one here. We usually see this early in the course of treatment. We escalate the dose with these drugs over months in order to mitigate the appearance of of the gastrointestinal symptomatology. But these occur in 30 to 40% of patients, usually mild, usually during dose escalation, as I said. They tend to get better over time, and then the patient does well. We rarely have to discontinue the medication because of these GI side effects. And the ways to kind of help the patient that have these, the big tool we have is just to slow the rate of dose advancement. Okay, you don't have to go according to protocol. You could slow. You take your time, and even the submaximal doses are highly effective. So I think that's number one. Or if you're at a certain dose in the middle of escalation, drop down to the lower dose. This is how we help patients primarily. We also encourage patients that eat small meals without a lot of fat content, and that can help patients as well. We usually don't have to go too much to anti-nausea drugs or antiemetics. Just really don't have to do that very much. If slow the dose rate of escalation, drop down to a lower dose, work with smaller meals, low-fat meals, I think that helps many patients.
Does that bother you that this is medication that they may have to take for life?
Well, sure. I don't like to. I mean, I'm a patient too, and I don't want to take a medicine for the rest of my life. But it's a chronic disease. The pathophysiological drivers that are operative in creating excess adiposity in the first place, and these drivers sustain that level of adiposity with weight loss. They drive weight regain. Obesity protects obesity from that perspective. They're there for the lifetime. And that's why we could get weight off of people with lifestyle interventions successfully, and that works for patients. But many patients have a hard time with that over the duration of their disease, and they have weight regain. That's because the pathophysiology is still there, and these medicines directly attack those mechanisms to suppress appetite and lead to weight loss. So, I think, but what we do need, Alan, is we need more data on how to manage this disease over the long term using these medicines. Can we use a lower maintenance dose? Can we use intermittent treatment? And I can tell you there's they're starting to design clinical trials where they use the maximal dose, patients get down to their equilibrium level of weight loss, and then they get randomized to a lower dose, maintenance dose, to see how long that would keep the weight off. So we are going to be getting data, but we need more right now. I can tell you these patients come up to me and say, "Well, Dr. Garvey, I've lost my 12% weight loss. I'm really happy about that. My blood pressure's down. I'm feeling good. I'm getting around better, but I'm sleeping better, but I'm not losing any more weight. And I don't want to just keep paying for this medicine, so I'm going to stop." And so, you have to, have a contract with the patient in essence, say, "Okay, I understand. But I want you to weigh yourself at intervals. And if your weight goes over a certain level, you got to come back in. We have to restart the medicine." So you can develop these kind of approaches on an individual basis, but I tell you, we just need data on how to manage this disease over the lifetime using these very effective new medications.
Well said. let's talk about the future a little bit, because I think the future is pretty exciting. I mean, there's like the triple G coming on, with this retatrutide. I hope we get to be, testing in patients with prediabetes and diabetes, and there's possibly the application of these medications for other diseases. Because, face it, I mean, I think we're addicted to food. Could it be a drug that we use for drug addiction or even alcohol problem?
Well, I can tell you anecdotally, and not just my anecdotes, but from a lot of colleagues, on these GLP-1 receptor agonists, these second generation GLP-1 receptor agonists, patients lose their taste for alcohol. And I have some friends on them who were, they liked alcohol. They were, but they just lost their desire to, still nice guys and still a lot of fun, but they just lost their taste for alcohol. And it is being explored and more formally in clinical trials to look at alcohol addiction, as well as other applications as well. The insulin resistance is key to cognitive decline, Parkinson's disease, Alzheimer's disease. So there's trials there in terms of what can these, and also the anti-inflammatory effects of these medicines could be operative there. So yeah, and we all know, we know now, you mentioned the SELECT trial, cardioprotective, but there's the STEP HFpEF trial, which is a semaglutide in patients with heart failure with preserved ejection fraction, symptomatic class 3 to 4 symptoms with HFpEF, put on these drugs, and their symptomatology improved dramatically. And there was functional benefits in terms of the 6-minute walk test. So this improves heart failure, at least due to preserved ejection fraction. The FLOW trial, which looked at diabetes doses and diabetes, looking at renal function over time, was halted due to efficacy. We don't have the data yet, but we know that the primary endpoint was met. So these drugs are renal protective. We know from an earlier phase 2 trial that they improve NASH histologically. And tirzepatide, there's a lot of trials along these same lines that are ongoing. We don't have the data yet, but so it looks like they treat multiple aspects, multiple end-stage manifestations of cardiometabolic disease. So these are really good drugs for these patients that are at risk of both metabolic and vascular disease outcomes.
One of the main things that I like a lot about the semaglutide effect in patients with heart failure, preserved ejection fraction, is because the cardiologists didn't believe that they would work. They always believe in the obesity paradox. To see that losing 10% of your body weight helps you with your heart failure. Totally makes sense. Now that we have the data, we can really kind of agree. So I think the future is very bright, Tim. And thank you for kind of like helping us understand a little bit more this class of agent that has really kind of changed, the face of medicine, has improved the outcome of our patients with heart disease particularly. And I feel like it's changing so fast, so much, that maybe we should have this meeting at least once a year.
Yeah, with these new drugs in development, I'm telling you, we're doing some of the clinical trials ourselves, and I'm just amazed. Like I say, I think this will be seen as a landmark in the history of medicine. I think we're really at such a powerful transformational phase in treating obesity and diabetes and a number of the cardiometabolic disease outcomes that are associated with these processes. So this is such an exciting time to be in medicine, and hopefully both of us will be around a little longer and see where this goes.
I don't think we can retire the way this is going. Tim Garvey, professor of medicine at the University of Alabama, thank you very much for your time.
Thank you, Ellen. We'll see you all later. Bye-bye.
To learn more from our team of cardiologists, please visit us at MyHeart.net. You can also follow us on social media by searching MyHeart.net on Facebook and Twitter. And be sure to subscribe to this podcast so you don't miss our next episode.